So welcome, sir. And the topic is giant inguinal hernia, step to step. And the one thing he says, which I usually in presentation, follow the right and you are right. Your famous saying, sir. Welcome, sir.
Thank you very much. I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. I must thank my old friend Dr. Ashish Vashisht for accommodating me before the next lecture. And I'm going to speak on giant inguinal hernia, a stepwise approach. So many questions are there in our minds. What is a giant inguinal hernia? What are the types? Type 1, 2, and 3. Should I treat as I do the hernias surgery without further much investigations, or should we get the CT scan? If we have to get in the CT scan, what kind of CT scan has to be done? Whether it is only abdominal or abdominal pelvic, whether it is supine, which is going to give you the more information, or prone position onto the CT gantry, that will give you more information. And as we have seen in last, I would say in 1 decade, especially for loss of domain ventral hernias, that there are many publications and Tanaka score, Sabag score. So are they ultimately helping the surgeon or not? Then role of preoperative progressive pneumoperitoneum or botulinum toxin, or what kind of approach is the best for these kind of giant inguinal hernias, open or laparoscopic, and what are the complications we should be afraid of? Rest of the routine complications, all of us know, but abdominal compartment syndrome, all of us have to be afraid of. Now, inguinoscrotal hernia that extends below the midpoint of inner thigh when standing and or long-standing loss of domain. And that is the definition of giant inguinal hernia. And then type 1, type 2, and type 3 depends on it is crossing up to the mid-thigh or it is going even beyond the knee joint. As I mentioned, the most important is that we should get the information on prone when the patient is lying prone on the table, and one should always be able to see the volume of the abdominal cavity as well as the volume of the hernia sac, and then ultimately decide that yes, what are the contents which are there in the inguinal region and the inguinoscrotal region, and how are we going to calculate the volume of the abdominal sac as well as the peritoneal, the inguinal sac. And most important, before even I see the patient in my OPD, my thoughts are that one should always have the thinking that this patient should not land into abdominal compartment syndrome after reduction. Anyone can do the surgery, but you have to come out of the surgery also. So if there is a sustained increase in intra-abdominal pressure above 20 millimeters mercury, which is normally is 5 millimeters mercury, and it is associated with new organ dysfunction or failure, then definitely one has to be cautious. And one should be conscious about the wound adhesions and hernia recurrence. And if it is, the chances are that these kind of patients, if we do not do the justice, then the recurrence, hernia recurrence is of the order of 30%. Tanaka index, most of us have been using in ventral hernia repairs, but it is not much useful in giant inguinal hernia repairs. But ultimately, we should extend, and we may find some information on it, that it is the, basically one has to divide between the hernia sac volume and abdominal cavity volume. And if it is 25%, if it is more than 25%, definitely the loss of domain is there and one has to take care. And similarly, Sabag index also, it is again used for ventral hernia repairs, not for giant inguinal hernia repairs. And again, more than 20% is the ultimate that one should know that it is going to cause challenges or it is not going to cause challenges. Now, I would put it this way, that there are many approaches which have been defined. Or one is open approach. And if we do by the same way as we have been doing by the inguinal hernia repair, by a bigger incision, a large incision, and then go into the pre-peritoneal space and do the Nahes and Stopa technique of giant processes being placed, then definitely the chances of hernia repair are good. But again and again, in the back of my mind, it should be that whether I am going to cause a abdominal compartment syndrome or not. And one can do the Lichtenstein if it is type 1. And there is another beautiful technique which has been described, and that is called as hug technique. Hug means like this, hug technique, that these surgeon, Caveli, had pointed out, and I will show you the photographs also, that ultimately if we do the hug technique and if we do not open the sac, but we reposit the contents into the peritoneal cavity, the chances of reduction are also very high and the chances of recurrence will further reduced. And then once the open surgeries can be done, should be done, and if we have decided for laparoscopy, I would be the person to go in for diagnostic laparoscopy first and then decide, and whether it has to be done by TAPP with internal ring occultation or constriction, or TEP or ETAP, or one has to go in for component separation. And in this hug technique, it was seen, very clearly seen, that if you hug the sac, big sac, but the intestines are still in, and you are trying to give an incision from pararectus space and going into the base of the scrotum, and if we are able to reduce, because all of us have struggled with laparotomies in many situations, that intestines start pouting out, one from this side, one from that side, and we are not able to reposit it back. So hug technique definitely helps. And this is the patient, you had seen the CT scan also and the video also. So we went in and we found that on the left side, the hernia had already been reduced. But on the right side, even if we had tried our best, after induction, we try our best to reduce the contents of the hernia and then start with diagnostic laparoscopy. But in this situation, you can see that the intestinal contents were there, and the CT scan has also revealed that there are colon and a small intestine. And once we are able to reduce it, and the patient is put in on head low, then we start with TAPP. And our thinking is, yes, peritoneum is single cell thick layer. We should carry on remaining close to the peritoneum and then make as large a space as possible. And again, it is a totally or pre-peritoneal space. One has to make sure that the mesh is going to rest in the pre-peritoneal space. And then in this situation, there are many surgeons who would go in with one incision, but we still believe on bikini incision. Means we start from the right side, go on to the left side, make separate incision onto the peritoneum, but the caution is that we are using a mesh which is 30 by 20 centimeters. Means rather than thinking that there will be overlap in the midline in the cave of Retzius, if we are able to shove in the 30 by 20 mesh through 15 millimeter port, then the chances are that we will not have the recurrence on the right side, on the left side, and then ultimately our aim is as simple as that. We have to go in for duct recurrence. And then we should always make sure that we are placing the mesh, fixing the mesh, and making sure that it is resting absolutely comfortably. And then we stitch the peritoneum so that ultimately there are no chances of any recurrence. And again, it has been reported wide, and this is the latest publication, that laparoscopic approach definitely is associated with faster return to daily activities, less post-op pain, fewer incidents of chronic pain, and the recurrence is also less. But again and again, the piece of caution which I would love to say at the end of my presentation is that please book the ICU room, surgical ICU, so that patient should not have the abdominal compartment syndrome. CVP line has to be placed, arterial blood gases have to be seen again and again, and then the respiratory complications should also be not there, but only thing is they have to be planned. It has to be planned, not after they occur. If they start occurring, if the abdominal compartment syndrome occurs, definitely it becomes a lethal complication. It can. And then the one has to be bothered about the usual complaints, complications like scrotal edema, seroma, surgical site infection, hematoma, inguinal of the order of 30%. And again, the basic thing is recurrence should not occur. And as my time is going to be over, so we should always be bothered. If you're good in TAPP, offer the TAPP. If you are doing TEP, yes, but we are doing ETAP for these giant inguinal hernias also because of the comfort level, because of the space level. These will be patients who are going to have a compromise of their cardiorespiratory reserves. So if that kind of situation is there, one should go in for supine. But if, for example, young patient is there, giant inguinal hernia repair, prone position is going to give us more information than the supine position.
Thank you, sir. Thank you so much. Can I invite, sir? Thank you.
Thank you. Thanks a lot. God bless you. Thank you.